Good afternoon, everyone. Thank you. Good afternoon. Welcome. You bet. I'm glad we're all getting situated here. Thank you all for making time this afternoon to join this talk. And importantly, also, thank you for making time to return to campus. It is a pleasure to see all of your faces after so long without on-campus reunions. So welcome back. Have a wonderful time. Thanks. So you're all aware this is going to be recorded as well as live streamed. So we may have the opportunity to field some questions from our folks tuning in remotely as well. So if you are out there in the world, don't hesitate to pop your questions in the chat. And of course, once the time comes for questions, we'll be fielding them down here at the front. We'll ask you if you will not mind to queue up to ask your questions, and Dr. Johnson will cycle through them. Any other questions before we get started? Let's get to the main event. Fantastic. It is my great pleasure to introduce our speaker this morning. He has an incredibly impressive bio that I confess I have to focus on. So I'm going to take a look down here. Dr. Matthew W. Johnson, PhD, is professor of psychiatry and behavioral sciences at Johns Hopkins. He is one of the world's most published scientists on human effects of psychedelics and has conducted seminal research in the behavioral economics of drug use, addiction, and risk behavior. Dr. Johnson earned his PhD in experimental psychology at the University of Vermont in 2004. Working with psychedelics since that time, in 2004, Dr. Johnson published Psychedelic Safety Guidelines in 2008, helping to resurrect psychedelic research. As principal investigator, he developed and published the first research on psychedelic treatment of tobacco addiction in 2014. Dr. Johnson and colleagues published the largest study of psilocybin in treating cancer distress in 2016. His 2018 psilocybin abuse liability review recommended placement in Schedule 4 upon potential medical approval. He is principal investigator on funded studies investigating psilocybin and the treatment of opioid dependence and PTSD, and has been interviewed widely by media about psychedelics and other drugs. Please join me in welcoming Dr. Johnson, the Susan Hill Ward Professor in Psychedelics and Consciousness and Professor of Psychiatry and Behavioral Sciences.
Thank you very much. Yeah, it's especially great to, I think this is the first gathering of this size at Hopkins, or maybe anywhere. Well, only a couple of exceptions outside of Hopkins for a couple of years now. So this is awesome. So thanks for that, and thanks for your interest in the work that I'll share with you. And I really appreciate the opportunity to share this with you all. So as you've heard, I'm going to be talking about this research that my colleagues and I have been conducting with psychedelics. Myself, I've been involved with that for about 18 years now in my time at Hopkins. Let's see, I'll see if I can advance slides here. Okay, there we go. Before going any further, just want to note by way of disclosure, I do serve the role of advisor for several companies that are developing psychedelics or analogs along the FDA pathway as medicines. So I just want to note those, although I'm not going to be talking about the work of any of those companies or any of their particular products, just the general relationship with psychedelics. So the work I'll be telling you about largely involves a compound called psilocybin. This is the active agent, the psychoactive drug in over 200 species of mushrooms. Pharmacologically, in other words, the way it works in the brain, it's what we call a classic psychedelic. And that means it exerts its effects by activating a subtype of serotonin receptor. So there's multiple serotonin receptors. Psilocybin and the other classic psychedelics activate the serotonin 2A receptor. And so that basic mechanism in the brain is shared by not only psilocybin, but LSD, mescaline, which is in peyote and some other cacti, dimethyltryptamine or DMT, which is in the South American sacramental concoction, ayahuasca, if you've heard of its religious use, these are all classic psychedelics. So there's other drugs that are sometimes called psychedelic, and that's using a more general use of the term. So for example, MDMA, you might know as ecstasy on the street, or ketamine. These are drugs that are, again, are called psychedelic, but they operate by substantially different mechanisms. So the risks and benefits from those are substantially different. They're in their own, they're in different classes. So the use of psilocybin containing mushrooms, by the available evidence, it's quite ancient, both historical and prehistorical. So on the left and in the center, I'm showing you artifacts from Mesoamerica and South America, suggestive of use dating back to several hundred to a few thousand years ago. But on the right, I'm showing a cave painting from Algeria, Northern Africa, that's suggestive of the sacramental use of these mushrooms. And that's dated to an estimated 9,000 years ago. So these are cave paintings in Algeria. And if you can't see it very well, say it's arguable, but there's a group of little figures, and their heads appear to have turned into giant mushrooms, mushroom caps, and they're holding many mushrooms in their hands, and they're kind of dancing around. Again, arguable, but I think highly suggestive, inconsistent with other evidence from the area. So that's the truly prehistorical part. I mean, that's 9,000 years ago. That's several thousand years before the first human civilizations in Mesopotamia. And so then if we fast forward quite a way, several millennia, we get to sort of this first heyday of research in the modern world with psychedelics. And that was really prompted by Albert Hofmann's synthesis and discovery of the psychoactive effects of LSD in the late 30s and early 40s. And this was primarily with LSD. These drugs were intensely investigated during those days as research tools and as therapeutics. So there were promising preliminary findings for both using LSD to treat cancer patients who have substantial existential anxiety about their pending death, and also using LSD to treat alcoholics. And we've generally picked up on those general threads of cancer-related distress and addiction treatment, as I'll show you. But then, unfortunately, we kind of entered the era of the dark ages. Despite some promising preliminary findings, research with these compounds in humans really stopped for a few decades. And this was a reaction, one, to the very real casualties as we got moved more from the mid-60s into the late 60s. LSD was becoming more popular as a recreational drug. And also it's important to keep in mind that the average doses of LSD on the street were about 6 times larger than what they are these days. The average hit of acid has 50 micrograms. Back in the day, it was 300. So if you find some psychiatrists in their 70s and 80s that remember those days, they'll tell you stories about folks coming into the ER on bad trips, and it was not pretty. And this is to be taken seriously. It's a real phenomenon. However, there was a failure to distinguish between the risk profile when this became popular with a bunch of young people largely, many of which obviously not using in the safest of circumstances, and some of which having psychiatric vulnerability, conflating the risk profile there to what we were seeing in the medical research at the time, where although there was some unethical research going on, the more typical research was aware of the risks associated with these compounds and were applying safety guidelines. And so if those were the dark ages, you could say we've entered an age of enlightenment again, or it's been called a psychedelic research renaissance. Here I'm plotting the number of scientific papers per year with psychedelic or hallucinogen, which is a synonym, in the title of the paper. And you can see that bounced around going back to 1980, 5, 10, 20 papers a year. But then we get to the early 2000s, which is about the time I was lucky to get involved with this work. And you can see there's this exponential increase in scientific interest. And even though a lot of this it does include animal work and basic mechanistic work, brain work, I would say even all of that has largely been inspired by the last 20 years of these accumulating positive therapeutic findings, some of which I'm going to show you for psilocybin. I don't have time to go into the what I call the dark side in detail, but I want to let you know that it's there and that I've made it a focus of my career from the very beginning in this area to shine a light on this and to make sure that we are applying appropriate mitigation strategies. So I published a paper in 2004, guidelines for safety in human hallucinogen research. More recently in 2018, anticipating, depending on phase 3 results, the potential medical approval of psilocybin as a medication, we were asking the question, reviewing a half century of literature, how should this be scheduled? If it's moved out of Schedule 1 to allow for medical use, what's the appropriate way to regulate this? And so we made some proposals there. But in terms of what we know about the risks, I don't have time to go through all of these. The biggies are sort of a small percentage of the population that is identifiable who have a predisposition to psychosis and schizophrenia and other psychotic disorders, and also bipolar. It appears through clinical observation that these people can be destabilized with a strong psychedelic experience. So that's a risk, people with that history, with that predisposition. And the more common bad risk that anyone can have in anyone is what you've heard of as the bad trip. In our clinical context, we call that a challenging experience because oftentimes you do have difficult psychological material that the person is dealing with during their psychedelic experience, but that the person often afterwards will say, well, that was very useful. Like it was difficult, but I had to go through that difficult material, either sadness or some fear, and kind of go through the other side. The really bad thing is when someone's in a uncontrolled environment where, and it's rare, admittedly, but it's a real signal. Like sometimes people, when they're intoxicated on psychedelics, will do something dangerous. They'll panic and they'll run into traffic and get hurt or even killed. Again, there's a signal there. It shouldn't be surprising at all. That happens with every intoxicating substance, including alcohol. So there is that signal there with these drugs. Importantly, across all of these risks, we know how to identify them and to address them through screening, preparation, monitoring of sessions. We're not sending these drugs home with people. I'll tell you more about that. And through follow-up care where we probe for any lingering adverse effects. One important risk that I will mention that is typically there for a drug of abuse, and to be clear, psilocybin is a drug of abuse, simply meaning it can be used in a way, and sometimes is, that can harm that person or other people. So an obvious example of that is driving. When someone's taken some mushrooms, they're intoxicated. But by addiction, we mean compulsive drug seeking. And we know that these classic psychedelics aren't addictive by any number of levels of analysis. The way they work, or rather don't work, on the brain's mesolimbic dopamine rewards pathway. We know from the large scale epidemiology, the survey research, especially if you make sure you don't include those drugs from other classes like PCP and ketamine and MDMA. If you look at just the classic psychedelics, that it's very clear there's not an addiction signal there. Again, it doesn't mean they can't be abused or used dangerously. So that's important to know, especially because some of the data I'm going to show you is relevant to its use in the treatment of addiction. So I'll move on to our first clinical disorder that we've treated with psilocybin. And I'll say I'm going to give you all a bird's eye view of this work. So not digging into the details, but I'm trying to show you well over a decade's worth of work here. So hopefully it makes sense in broad strokes. This work with cancer patients was with 51 participants. They all had some form of life-threatening cancer. The form of cancer differed across people. They all had to satisfy one of several pre-designated psychiatric disorders, either involving depression, anxiety, or both. And about a third fell into each of those three categories in terms of their symptoms. And it had to be about the cancer, had to be prompted by the cancer diagnosis. Everyone received 2 sessions. It was a within subject design, a crossover, meaning everyone served as their own control. They had 2 sessions. The order was randomized. One of the sessions was the real deal high dose of psilocybin. The other was a dose so low it was really intended to serve as what you can call an active placebo. We wanted to honestly tell everyone that you're going to receive psilocybin in each session, but the dose may differ. And so basically keeping people on their toes in the context of this double-blind study. So we simply randomized that order where they got the high dose first, and then 5 weeks later, the trivial or low dose, or the opposite order. And then we followed up after each session at 5 weeks to look at symptoms, and we followed up at 6 months. And so here I'm showing you our primary depression and anxiety outcomes, the Hamilton Depression and Anxiety Inventory. These are clinician administered scales through structured interview. At baseline, people came in at, and if you're not familiar, you probably aren't with these scales, but they're coming in at the baseline on the left of both these scales, in the 20s. That's in the severe range of the scale, high levels on average of depression and anxiety. You can see at post 1 on the x-axis, now the red group, this is the group that's been randomized to receive the high dose of psilocybin. You see that both those groups had very high levels of suffering before they were randomized, and as you would expect, they didn't differ. But now the red group plummets. They've received, this is 5 weeks after they've received the real deal high dose of psilocybin. There's also a substantial reduction in the blue group that's received the trivial dose at that post-time 1. That's probably due to what we call the placebo effect or the expectancy effect, but also 8 hours of preparation for these sessions where we not only prepare people for what they might experience during the session and how to handle it, but also discussion about their cancer and their life history, which is surely therapeutic to a degree. So nonetheless, that reduction you see in the blue group is nowhere near as large as what you see in the red group at post-time 1. And then at post-time 2, 5 weeks after, this is 5 weeks after the second session, now everyone's received the high dose of psilocybin, whether it was 5 weeks ago or 10 weeks ago. And so now the blue group has 5 weeks before received the high dose. And now they are down to those very low levels along with the red group of low levels of suffering. And I'll say on average, this is the range of the scale that is not indicative of having a disorder. So it's the normal range of the scale. And virtually the same pattern unfolds for depression and anxiety that I've just described. So dramatically large reductions. At 6 months, it's astonishing that we see those reductions in depression and anxiety remain low. I mean, the closest thing we've had in the field is ketamine will reduce depressive symptoms immediately and last for about a week on average. Here we're seeing evidence of 6 months at least. And that was our last follow-up. It's not what we've seen that it increased at that time point. So we can say it's lasted at least 6 months. The next part of the data I'll show you relates to the nature of the experiences that often happen with psilocybin. And a construct that we've looked at quite a bit is what's known as the mystical experience, which sounds quite woo-woo. It makes you think of, I don't know, crystal balls and dream catchers maybe, but it's a validated psychological construct that has roots dating all the way back to William James, the father of American psychology 100 years ago. And the idea of this is, outside of drug use, there was this fascination with the idea that if you look across cultures, across centuries of history, across different languages, across cultures with different religions, you'll see reports of human experiences that are quite extraordinary, whether they've been prompted by prolonged fasting or prayer or acoustical techniques or sensory deprivation or sometimes near-death experience. And sometimes out of the blue, but there are these extraordinary experiences that people report that look remarkably similar to each other, despite all of those differences that I discussed, suggesting that maybe this is something that the human animal does, regardless of culture, something that the human animal occasionally experiences, this so-called mystical experience. And what that refers to, what that experience is, it involves these factors: having a sense of unity that can be expressed in many ways, but feeling at one with the universe, feeling at one with the rest of humanity are examples. A positive mood to the experience, and a sense of transcending time and space, as if stepping outside of the bounds of time and space, and an ineffability to the experience, meaning referring to, you ask them to describe it and they say, it's so far beyond words, I can't even begin. Like they're claiming ineffability right there. So we found that this is a relevant construct time and time again. In this cancer work, we found that when the drug wore off, and it lasts about 6 hours, and before we send them home with a loved one, at the end of that day, we assess the mystical experience, and with a validated a measure that assesses those factors by self-report. And then we look at their symptom levels 6 months later, and we see that that mystical experience on the session day is significantly correlated to the level of reduction in anxiety and depression 6 months, I'm sorry, 5 weeks later before the crossover, which is quite remarkable. And even more remarkable is that those statistical relationships, that correlation held up even after we statistically controlled for their ratings of drug strength. In other words, how intense the drug session was. So what this tells me is that there's something about the nature of what they actually experienced during the session, something about the experience itself, and not just being hit over the head with the sledgehammer of a strong drug effect. There's something about the nature of what they experience that they can learn from. And I'll speed up a little bit for sake of time, but I'll just say that in the same issue several years ago, our colleagues at New York University published a somewhat smaller study, but coming to the same findings, very large effects that were persisting in cancer patients of psilocybin reducing depression and anxiety. Outside of cancer, colleagues at Imperial College London published the first very small open label study finding decreases in depression, and this is outside of cancer, so just people with major depressive disorder, and finding some indication of lasting antidepressant effects from 2 sessions here that lasted 3 months. And we then published the first randomized study. This was an open label study, so people knew if they were getting psilocybin or were they were randomized to a group that was simply supposed to wait several weeks to have their 2 sessions or to have them relatively immediately after preparation. We saw in the group randomized to receive psilocybin large reductions of a similar size that I've shown you already in the cancer study, large reductions in depressive symptoms here measured with another form of the HAD scale, like the one I showed you before. And we didn't see that change in the folks that were randomized simply to wait. And then even more recently, our colleagues, again at Imperial College London, published a study that looked at this under double-blind conditions and compared it to a standard SSRI antidepressant and found some trends for psilocybin to show stronger antidepressant effects. I'll move quickly into the anti-addiction work. So I told you psilocybin doesn't appear to be addictive itself. It's quite another to expect it to treat addiction. Why would we think that? Well, there's these several older studies in the 60s looking at LSD and the treatment of alcoholism. That was described as sort of a mixed bag in the literature. Some of the studies found statistically significant improvements, some studies didn't. But a meta-analysis from a decade ago found that in aggregate, it was a very clear statistically significant signal, as indicated by the large diamond, which represents all of the studies aggregated across those studies. And basically what it's telling you, the odds ratio of about 2 is telling you that at the first follow-up that the people that received LSD were about twice as likely to be improved compared to people in the various control conditions. And those control conditions varied across those 6 studies, but there was a clear signal across the study. So we, and I'll mention there's one other previous study actually conducted here in Baltimore, published in the early 70s, that found some promising effects of LSD to treat heroin addiction, and with even some biologically confirmed success rate through urinalysis at a 12-month follow-up, which was, again, really promising, but yeah, the rug was pulled out from underneath all of these studies right around the time when those studies were being published. So there was sort of the signal of potentially an anti-addiction signal across different forms of addiction. So combined with those older studies, there's these anecdotal reports and some survey reports of people overcoming addiction across cocaine and methamphetamine and cannabis and you name it. And so with this in mind, I decided, hey, let's look at cigarette smoking. This is well over a decade ago, and see if there's a signal there. And I had found some anecdotes online in this direction. So I said, hey, let's set up a pilot study to look at it. And we hustled up a small amount of money thankfully to look at this, and we got a really positive early signal. I will say it's always nice to get some coverage of your work, but you don't control the headlines or the photos. And even the reporters don't usually control the headlines and the photos, but you've surely gotten the impression by now that I'm not encouraging anyone to use it themselves outside of an approved context. There are definitely risks, but I definitely want to especially emphasize this. Don't do that many mushrooms, especially. That's crazy. I mean, we do give a high dose, but wow, that's a lot of mushrooms. So for the results of our smoking pilot, the important parts here, these are 15 people, been smoking on average for over 30 years and smoked on average almost a pack a day. So they weren't lightweights. We combined it with typical talk therapy for helping people quit smoking. There were 3 psilocybin sessions. I'm going to go kind of fast just to hit the broad strokes here, but they were going to quit smoking on this target quit date, which we assigned several weeks ahead of time. And that was going to be the date of their first psilocybin session. And this is carbon monoxide readings. This is like a breathalyzer, but for smoking rather than for alcohol. And you can see before and after the first psilocybin session, clearly a pre and post difference there. Looking at it a different way at various time points, like 6 months after the target quit date, 80% of them, 12 out of the 15, were biologically confirmed as abstinent. And at 2.5 years or 30 months, that held out to 60%, which is very high compared to what's typically found with the best smoking cessation treatments. And again, we found that mystical experience on the session day was related to long-term success. We've done some qualitative analysis where we've interviewed these people 2.5 years later, and we said, well, did this help? Do you think the psilocybin session actually helped you quit? And if so, how? And they mentioned a number of things that future work we're going to have to tease apart, but they said left them with a sense of interconnectedness, awe, curiosity. It reduced withdrawal. It also came with other positive psychological changes like increased altruism. And folks said that they had insights into their own self-identity and their own personal reasons for smoking. And here, I'll let you, depending on how fast you can read, kind of absorb some of that. But we just, these are some quotes that we published in our paper. Interestingly, like a lot of what people are saying, sometimes they don't even mention like smoking. It's more of these high level, like seeing oneself as more about an identity, the identity being this construct. Well, that's consistent with this idea that, hey, I'm no longer a smoker. People convinced I'm just a smoker. I'm a failure. I've tried a million times, but it's like, no, I'm something beyond that. I can be a non-smoker. So anyway, I think we're really hitting this construct of what it means to be addicted, even if it's like just to tobacco, which some of us, may have this impression that it's an easier addiction, but it's often when you really get to talking to folks, these are deep-seated issues with life priorities. It's inconsistent with the way they're living their life in other ways, and it's a deep source of conflict. And I don't think I think we have the ability to get at that with these psilocybin sessions. It's not necessarily there with most addiction treatment. So we're in the midst of a randomized clinical trial right now. 100 people are being randomized to the psilocybin treatment. In this case, only one session versus a course of nicotine patch using the standard FDA label, the instructions for the nicotine patch that you'll get if you buy it over the counter. And it's in process, so these results aren't official, but I'll show you data from the 61 people that have gotten to their 1-year follow-up. Again, these are not lightweights. They smoke about 16 cigarettes a day. Been smoking over 25 years on average. For the 61 people that have gotten to the 1-year follow-up, and maybe I'll tweak the video screen, so yeah, you can see the results there. But at the 1-year follow-up, it's the 31 people in the psilocybin group right now, 59% are biologically verified as abstinent compared to 28% in the nicotine patch group for the 30 folks in the patch group that have gotten to the 1-year follow-up, which is very high for the patch. So these results could change, but just want to emphasize that they're not official yet, but so far they're very promising. And based on those results, we were fortunate. Been trying this for a number of years, but we received the first, to our knowledge, the first federal grant from the United States to look at the therapeutic effects of one of these classic psychedelics like psilocybin or like LSD in a half century since that heyday in that ended in the late 60s. So we're going to be continuing this work in federally funded multi-site trial along with New York University and University of Alabama, Birmingham, where some of this psilocybin research is going on. And speaking of that, a very similar trajectory of work. My colleague, Mike Bogan, who's now at New York University, he published this work at University of New Mexico, but very similar trajectory where he published a small pilot study with psilocybin in treatment of alcohol use disorder and found some large reductions in drinking days. And so he recently finished up a large 100-person study. And the real challenge in this field is like, how is it working across these different disorders? Like, it's weird enough to see something working for different forms of addiction, much less like addiction and depression, like what's going on here. And this doesn't sound very scientific, but Michael Pollan wrote a very interesting book, How to Change Your Mind, about this kind of modern psychedelic mental health research. And he credited me with this, like saying it's like a dope slap, which sounds like a horrible scientific name, but I think it's pointing to something. Hopefully we'll be more refined and figure out, but this is how I kind of say it at the gut level. It's like people, whether they're addicted to a substance or whether it's the story of the depression or the cancer, they've been sucked into this very narrowed mental and behavioral repertoire. Their world has become so focused on that one thing to the exclusion of other life priorities. And so that is a commonality. I even think of depression and sort of a problematic relationship with an illness that's really where the suffering is largely coming from your own psychological reaction to it. These are forms of addiction. These are forms that it's easier said than done, but people get stuck in these narrow mental repertoires. And somehow these sessions seem to dope slap people out of those stories. And so I think there's a lot to figure out how, like in terms of the neuroscience and psychology, what's underlying that. We've got some ideas, but that's the best I can put it right now. But we're doing a whole lot of studies that are ongoing and that we have upcoming very soon. So stay tuned. I think this field is very interesting. One of the things I published that we're gonna have to watch out for is that, having a treatment that does butt up against, for some people, the spiritual. I think it's very important that we be metaphysically, like we let the patient drive the bus with that. It's not our place to say what the ultimate nature of these experiences. If someone thinks it's a glimpse of God or some glimpse of the nature of reality, that, or if it's just a monkey wrench in the brain that might have some useful effects somehow, we really have to be, neutral on that, because our expertise can tell them what receptors being hit in the brain. But in terms of these larger questions, there's a real danger for scientists and clinicians to go off on the guru route, and people can form cults around this stuff. We need to very, very much cling to professional boundaries in this work, because there is a danger there, in my view. But I'll stop with that. That's just kind of a big picture reflection of something we have to look out for in the field. But I've shown you a bird's eye view of a whole lot of work. So I have a ton of people to thank here at Hopkins. So I thank all of my colleagues, and I've surely forgotten some because it's so many people. So I've apologized. But if you want to find out more about our group, it's hopkinspsychedelic.org, and you can find out more about our ongoing studies. Hopefully I've tried to shoot for I only went 5 minutes over what I was shooting for. So it sounds like there should be some time for questions. Thank you. Yeah, so I think we're doing the mic here. So yeah. Unless someone has any mobility issues.
Yeah, thanks for a really interesting talk. I have a couple of questions that sort of wrapped up in one general question, which is, one of the most prominent features of psychedelic use is the out-of-body experience. I'm wondering is that a dose-response effect? Is it an off-target effect of psilocybin or LSD? And then have there been any fMRI studies done to try to ascertain the different regions of the brain that might be involved in that?
Yeah. There is a dose response to those types of effects. In terms of whether the therapeutic effects that we're seeing are dependent on them, we don't know. We do have evidence, as I showed you, that some aspects of the subjective experience seem to be related, which correlation isn't necessarily causation. So we even have to keep that in mind. But there's a real debate amongst folks that, in terms of whether even the experience at all is necessary. We do, complicating that question is that we do know that these compounds, even in rats, and some close analogs that don't appear psychedelic, they seem to unfold different forms of neuroplasticity in rats. Branching, synaptogenesis of forming new connections amongst neurons, dendritic branching, growing branches off of existing neurons, So multiple forms of neuroplasticity. So it's folks are and companies are working on thinking, oh, you can avoid the experience altogether and get some sort of therapeutic application from that. So it's really, we need the definitive answers. We need to do the things like knock someone out on anesthesia, and there's compounds of that. There's compounds of any way to address this question as far as I can tell, but we can definitely start to triangulate an answer. I will say, yes, there's a lot that's known on the fMRI front. I think the most meaningful thing that at this point is, I think the meaningful level of analysis is resting state connectivity, and some radical changes happen in connectivity. So this is not about which areas are activated, more active or less active, but more about the synchronization about activity across areas of the brain. And what that is presumably a proxy for is communication patterns operating at the neuronal level. So you see this increased activity across the brain globally, but at the expense of some local network activity. So to put it plainly, it really, the brain looks very, very different in terms of how it's communicating with itself. And that seems to be correlated with subjective effects. So, but there's a whole mystery about what the potential long-term biological effects that are going to be correlated, not just with the experience, but with the therapeutic efficacy. So in other words, we have a lot to figure out. I'm sorry.
I have two questions. One is, do the researchers in this area also experience the effects of these drugs? In other words, you take the drugs yourself in order to understand what's going on. And second, what exactly is the protocol for stopping smoking using this? I mean, do you use a talk therapy over a period of time plus repeated dosing, or just if you?
Yeah. So there is one protocol by a group of you doing work with MDMA, which I didn't mention here, which it's not a requirement, but actually it's an FDA approved protocol where the therapists are allowed to have experience with the drug, and they're wrapping study questions around that to make it so it's a legitimate FDA approved study. That's the only thing of that nature that I know of. Anything else would beyond that, like unless someone is of a certain age to have had those experiences before the Controlled Substances Act, anything would be illegal, or maybe it happened in another country. But anyway, all the stuff in that category, I think the important thing is, we get this question a lot, is I think it's best to focus on the patient's experiences rather than, the people who are doing the research. I mean, I think that was one of the big problems with Tim Leary. I didn't mention Leary in the talk, but at Harvard back in the 60s. And frankly, if someone said, oh yeah, I had a couple experiences back in college, there's a whole lot of people, that might have sparked someone's curiosity. There's a whole lot of people would say, wow, you're completely biased and I can't trust anything from you. And then if you said the exact opposite, said, no, it's always been an interesting thing, but I didn't want to do it because it's illegal or whatever, a whole other bunch of people would say this is completely unethical for you to do this to people and not know what you're putting them through. So it's really a no-win. So I just encourage folks, including young folks going in this areas, just keep it about the data. And yeah. So, and you might have had another question in there, but oh yeah. So it's very standard cognitive behavioral therapy. So we have them keep a smoking diary before they quit. In other words, when you do have a cigarette for these next 2 weeks before you quit, write down what situation it is. We get together, we could talk about just looking at your own patterns and you remind yourself when you do smoke each cigarette that you're quitting in a week and a half or whatever it is. And we give them some instruction on what happens if you slip and you do find yourself smoking a cigarette, how to treat that as a learning experience rather than dwelling in guilt. So all very kind of empirically supported, talk therapy that falls generally within the cognitive behavioral therapy approach for helping people quit smoking. But during the session, and I could have emphasized this more, I mean, for 6 hours, this is largely, unless they get up to use the bathroom, this is what it looks like. We're not doing any talk therapy during the session. So all that talk therapy is during the preparation and then in follow-up sessions. Here, we say trust, let go, and be open, and then we'll discuss your experience afterwards. Hi.
Can you hear me with the mask
Yeah.
on? Okay.
Yeah.
So I'm having trouble getting this as focused as some other questions, but I'm just come from the Alzheimer's lecture, and we heard about the public health consequences of Alzheimer's. Someone brought up, diabetes and all. I'm thinking of this addiction as the public health. And I'm also aware in Baltimore that we're trying to be a trauma aware city.
Mhm.
So I'm bringing that, I come from the social science side of this, actually
Yeah.
religious side of this. So my question is, with this huge public health burden and these sort of the inequities in Baltimore and the history, multiple generational history of racial trauma.
Mhm.
And then there's this voice about the drug wars. So there's going to be a lot of distrust of giving people of color any kind of drug because
Mhm.
powers that be are not going to be happy about that. What kind of future do you see of bringing what you're doing to the work of sort of a racial equity in treating trauma in this world and
Yeah.
maybe the city? Is there anyone doing that?
So yeah, but I mentioned the drug MDMA a couple times, which is in a different class, but there's definitely overlapping effects. There's really incredible work showing it to have effects in helping people with PTSD. They've conducted, in fact, it's more advanced in terms of the FDA progression, more advanced in the psilocybin work. They've published one phase 3 trial. So I'm going to be starting a study soon with using psilocybin to treat PTSD. So there's no data on that yet, but there are older data. There's data with LSD, which is, in terms of its neuroscience, very similar to, it's in the same category again as psilocybin, but people are using LSD with Holocaust survivors decades and decades ago, and there was lots of stuff published in the Netherlands about that. This stuff, and then there's this whole area of underground therapy, when this stuff was made illegal, people have continued to use it. There's a lot of folks out there that say the classic psychedelics like psilocybin can even work better than MDMA. So all that to say is we'll find out whether psilocybin is helpful. In terms of subtypes of trauma, absolutely. I mean, we're just in our infancy, and if you're talking, racially related trauma, these are great questions. We don't know. We don't have an answer to that. I think all of the research so far is just looked at PTSD from any number of sources. So I think as it progresses, that's a really important question.
One follow-up question.
Yes, yeah. Not here, but in actually a number, because it's a distributed phase 3 trial in about a dozen cities across the US. There'll be MDMA trials. Absolutely. Yeah.
Have you worked with bipolar patients at all?
No. And so yeah, and so it's interesting in this area, there's some anecdotes of people that have claimed that psilocybin has helped them with managing bipolar. There's also clinical observations where it appears that people have been worsened, that their mania has been worsened, and you add to the backdrop the stuff that was being published in the 60s, the diagnostic classifications. The people that were called schizophrenic then, a good chunk of them could have been called bipolar now. So there's a shifting diagnostic landscape. And so it may be that the bipolar we're including we shoot for an abundance of caution. And I think that's the place to start. But even the schizophrenia and the bipolar, the exclusion for those are based upon, well, there's at least it's not like there's any study that took premorbidly, people that showed early signs of schizophrenia and then you randomized to get these drugs or not. I mean, I think we know enough such that experiment would be unethical, because we know it's pretty decent shot it is going to make enough people worse that I would say don't do that study because you're going to hurt someone. So anyway, both of these are through clinical observation. I think we know enough that we should just proceed I'm not going to say it should never be looked at, but we should probably know more about psilocybin before specifically trying to treat bipolar. But I don't know. There's actually so much research that's going on now that I wouldn't be surprised if someone's actually started a study somewhere with this in mind. If they are doing it, I'd want really good expertise on bipolar specifically, not just winging it, I mean, surround themselves and really just having extra measures there to look like what are the signs if you do worsen mania. We want to know that right away. And if you see it in the first couple of subjects, you want to know that. And So this is what goes through the head when we start talking about exploring. So not to say it's never possible, and there are anecdotes of someone saying, "Oh my God, this cured my bipolar." That might be true, or it might not. Yes.
I'm struck by the sustained effects, especially with the clinical trials that you mentioned. So my question is, are you aware of anyone looking at pre and post sort of permanent type changes,
Yeah.
biochemical, anatomical? What's something to account for what appears to be a really long-term, if not permanent effect?
Yeah, and that's like, we don't have a good answer to that now. There are some findings in the field that are not necessarily tied to the therapeutic effects, but like in our smoking study right now, we're looking at long-term potential changes in fMRI and also any number of like neurobiomarkers. But no one has a good answer right now in terms of like, we know a lot about what mediates the acute experience, and we know that some aspects of that experience are correlated with long-term success, like being less depressed 6 months from now. But we don't know what's different biologically, 6 months later when they're smoking less or less depressed. And my best guess on that is like the improvements that we see with these drugs are ultimately similar in kind, and we published a paper on this recently, similar in kind to what we see in psychotherapy. In other words, people are actually learning something. They can, like a life event or an experience, like someone could say the first time I fell in love or first time I lived in another culture, they could say, I now view the world through a different lens. I changed. I'm not the same person I was. And this is something more like that, or they went through like, really effective psychotherapy that actually worked for them. And they've learned something. And we normally don't think of in science, like with a successful psychotherapy, like, I don't know, like, systematic desensitization for phobias. Like if you're afraid of spiders, first look at photos of spiders. Like that's one of the most effective treatments in all of psychology and psychiatry. I'm not sure if anyone knows how the brain has changed a year later. But presumably any change in behavior probably has a correlate in the brain. So I think whatever we're going to see, it's probably in the short term, the mechanistic of the compound opens a window of plasticity, perhaps providing an experience that one could potentially learn from if it provides different perspectives on their issues, combined with this kind of window of neuroplasticity that the rat work is suggesting. But then it's like, it's in the category of like psychotherapy of like that long-term changes are because they took advantage of that window to learn something and to establish a new normal. So, yeah. Hello.
I was just thinking about one of the graphs you had at the beginning showing how the research has really taken off. And I'm thinking that, I'm not sure where the legal status of it is now, but supposing as it becomes more legal, it's going to take off. And, I'm thinking there could
The
be
use, not just the research, you mean? Or, I'm sorry. I
Oh,
wasn't
yeah,
sure if
I
you were
mean,
done.
yeah, the research and the use
Okay,
and
yeah.
the commercial interest and all of that. And I mean, I didn't actually read Michael Pollan's book, but I heard an interview where he was discussing some of the kind of cultural politics of some of these substances. And I just wondered if you had anything to say about that and what it would do to the communities who have nurtured this over the years.
Yeah. It's definitely there's a lot of I think one should be concerned about, but at the same time, I don't think. Well, let's see. I think we need to do this research as a field and do it as safely as possible, and to not send the wrong message, and to tell people, I'm not doing this research to encourage anyone to use. But at the same time, there has been, I don't think it's only because of the research, but the world is very complex and interactive. But yeah, interest in these compounds has been increasing, dramatically in society, not just, independent of the research. So I think as a scientist, we just have to keep being very clear about here's what we know about the dangers and here's what we know about the potential therapeutic effects. And yeah, and
But in your center, would there maybe you specifically are looking at how it would be maybe regulated or something to prevent the kind of abuses we've seen with other.
Well, okay, yeah, so that is very much, I mentioned that paper from 2018 on the scheduling. So that's directly about like, if this is approved as a FDA approved medication, how should it be treated? So like recommendations there's a program that the FDA has called the REMS, the Risk Evaluation Mitigation Strategies, basically rules that they could slap on above and beyond the approval of a drug and say, okay, you can use this, but it has to be restricted to this. And there's certain examples of that, like drugs that you can't take home, like propofol. Unfortunately, it was given to Michael Jackson to take home, but you're not supposed to, and like you only get when you're getting an endoscopy or a surgery, for example. So it's going to be like, well, the recommendation is to be like that. Like it's not take two and call me in the morning. It's only with a certain amount of preparation and with the developing the clinical rapport. And basically everything I told you about how we do this. And so hopefully those recommendations are heeded, because, clinicians and companies may want to do things as cheaply as possible. And this is an intensive model when you're paying two professionals. So can we do it with just a camera? And we've just got to be careful and empirically driven and very cautious. And when folks try to do this on the cheap. So I don't know. Those are some of the things I think about. But yeah, the devil is going to be in the details in terms of how this, if we don't want bad outcomes that are unintended. So it's about regulating it the right way. Yeah. And other thing I'll add, if something's approved, most folks don't know. Methamphetamine is a Schedule II drug that you can get by prescription. It's usually not first line, but it's not like if this is approved, it means it would be legal. Cocaine is approved for medical use and methamphetamine is approved for medical use, and lots of opioids are. So yeah, that FDA approval doesn't necessarily mean legalization.
Roy Martin, class of '85. So during those dark ages, when I was here at Hopkins and I was experimenting with this on my own, a lot of the experiences were really profound and life-changing, as you've been talking about. And then years later, I did really, intense therapy, psychotherapy that lasted for years.
Yeah.
Which was also really profound and life-changing. It seems like if the two are combined, it could really accelerate that therapeutic process. Is there research going on in that currently?
Most of the research is combining it with therapy, minimally what's called just supportive therapy. I think even to do this ethically, you have to develop that rapport. So, just general get to know you, reflective listening, type of therapy. But then when we have certain things like smoking, I mentioned cognitive behavioral therapy for smoking, and people that are doing, the folks doing the alcohol work are using motivational enhancement therapy, another form of nominal therapy. But no study has actually looked at what if you extended that therapy or not? What if you actually embedded it within a long-term therapeutic context? And in fact, in the old days, in the 60s, there were a lot of the research was being done like that. In fact, it was called psycholytic therapy, where it would be more of an ongoing, usually lower doses. So instead of 300 milligrams or micrograms of LSD, it'd be more like 100 micrograms. So no, it's not a microdose. It's definitely a real psychedelic dose, but one that one could do on the, therapist couch, once a week, and kind of in a more ongoing basis and with the emphasis of a little different, to talk during the therapy. Whereas on a higher dose, the advice is to, hey, just shut up and let the magic happen. And you're there for support in case they're become anxious.
I can talk about what happened after the fact. Besides from that experience.
Right, because in these studies, and it differs by the study, but we'll have anywhere from 2, 3, 4, 5. The smoking study is actually the most, because we're concerned about keeping them on track with smoking. So it'll be up to, depending on how you count it, 10 weeks after the session. But yeah, a lot of studies will be 2, sessions afterwards. And we do include in consent forms and in the process of sometimes people, it prompts things like a midlife crisis where it's you might have been here about smoking, but all of a sudden this trauma from 40 years ago, and I've seen this happen in the smoking, comes up, and it becomes about this unprocessed trauma from 40 years ago. And it's don't do this if you're not willing for anything to come up, because it's not oh no, this is just going to be about smoking. This is plumbing the depths of the psyche, and there is no control about what this experience. So unless you're willing to completely surrender and to face your demons, what they may be, this isn't for you. And you really need to kind of essentially try to scare people out of it. There's people, I've had military vets in combat that said this has replaced that as the most intense experience of their life. So so I've had volunteers that have been through more intense experiences than me, and all I can do is relay there, like, don't take this lightly. So, yeah. I do think there's so much to be learned about embedding this into an ongoing therapeutic relationship, because it just, and I think it's multifactorial to the degree. One of the things that there's all these indirect ways in which this is therapeutically useful, like just to establish, regardless of the independent effects of the drug, the fact that you go through that with this person where you literally might feel like you're closer to death than you've ever felt in your life. And this is that person grabbing your hand, and like, what a bonding experience, what a leap of faith, where that person says, you may feel like you're going to die. You're not physically going to die because it's a very safe drug under these conditions, especially, but I'm going to be with you here, and I'm not going to leave you. And it's like, wow, what other condition? I mean, maybe like surgery, but you're asleep then, like where you're saying, I completely trust you to cut me open and do whatever you want. But again, you're not even part of it. So anyway, this is like a bonding experience I can't think of in any other realm of psychiatry or psychology. So I think so if you embed that into a years-long therapeutic, I mean, I think it has incredible potential.
Safer and better experience had there been something like that available for those of us who were doing it back in the dark ages on our own, because it was dangerous and reckless and stupid the way we were doing it. I certainly wouldn't recommend that for anyone. But thank you so much for taking this on. I know there's, this is controversial and there's career risk, and it's really profound. And important.
Thank you, and thanks for your insights. Yeah. Hi. Okay, couple more minutes, I'm told.
You mentioned those 4 different psychedelics in the beginning, like the classic ones, the LSD and shrooms and DMT and another one. And I'm wondering, could you like talk a bit about the differences between them, and if there's like significant differences, then like which one the research community finds the most interesting?
In terms of those classic psychedelics,
Yeah.
in terms of that, once we get inside the class, I mean, like if we compare all of those compared to MDMA, there's some, big differences. Like the bad trip is more of a classic psychedelic thing. It's more of an emotional experience, more of a reliable thing with MDMA. But within the classic psychedelics, it's mainly time course. Someone smokes DMT, it's going to be 10, 15 minutes. If someone swallows LSD, depending on dose, it could be like 15, 16 hours. And psilocybin is more of a 5 or 6 hour experience. So now there are people who do report other differences. Some people will say, oh, I can do LSD, but not mushrooms, or they'll say vice versa. But when you step back and you hear that as a researcher, it's like you just want to see it under blind conditions, because there's just a lot of variability. If someone says, oh, I have more bad trips with mushrooms, you're just as likely to find just as many other people say they have more bad trips with LSD. And the one reliable thing, now they all do have different receptor profile effects, like LSD has a little bit of dopamine, and the distribution of the other non-2A serotonin receptors, they all differ slightly. We do know that for all of them, 2A seems to be key. If you don't have 2A, serotonin 2A activity, it's not a psychedelic. But so surely those other, the different kind of cascade of receptor effects is coloring things, but it seems like there's more in common than there's different. And the one thing we can say for sure is like the time course is radically different. But subjectively also, they're the things that if you are in the category of DMT or 5-methoxy-DMT, those things that are actually smokable, in the whole idea that like it can actually like hit the receptors in a bolus, like quick dose, you do get more of a dissociative, like people, it's more routine for, and I've done survey research on that, those drugs where they'll say things like they were talking to aliens or disincarnated, like elves and entities and things like, that's more of a DMT thing than a psilocybin thing. And I think more about the rapidity of the onset, which again comes down to time course.
Okay, so I guess like what would be the difference between LSD and shrooms? Would it just be like a time course thing?
Yeah, most people say just LSD just lasts twice as long. I mean, that seems like the most guaranteed thing.
I see.
And beyond that, you can find some people that like this versus that, or vice versa. Yeah.
Thanks.
Okay. And I'll try to be super quick on my answer because I think we've got a minute. Yeah.
So I have a short question. How long before you can go to your physician and talk about this treatment as being available? What does it have to go through?
Probably 3 or 4 years for psilocybin. So it's close. It's in multiple 2B trials, close to phase 3, and you need 2 phase 3 trials. So I think 3 or 4 years. And obviously depending on results. I mean, those results, if they differ from previous ones, might be like, hey, it's no good. But if results hold up, 2-3 years. And I know you were going to ask a question. Okay. All right. Well, Thank you, everybody. And